First, we have to talk about who seeks out therapy and who's using therapy, particularly in the US. And so we know that about 15% of people use mental health services in any given year. That's a pretty high number, thinking about that's about what, 1 in 7? I'm not good at math, but that seems like it's about 1 in 7 or 1 in 8. So a lot of people seek out mental health services. There are more common reasons for this. Again, anxiety and depression, like we talked about last time, are two of the more common disorders. And so those are the ones that most people are seeking out treatment for. And not everyone that's using mental health services has a diagnosable psychological disorder. So that's also a key thing to remember. So not everyone who seeks out therapy has a certified disorder. Some people may just be having a rough patch. So remember, if the disorder or if the problem isn't disrupting your life and it's not long lasting and it's not functional, we don't consider that a disorder. That doesn't mean that you don't benefit from therapy. It just means you don't have a diagnosed disorder. And so not everyone that seeks therapy, sometimes people just need a little extra help, someone to talk to, things like that. And that can be really beneficial to anyone at all. People most likely to use therapy are women. And again, we see women more with anxiety and depression, so that kind of makes sense. People with insurance, seeking out therapy is very expensive in our country, and so if you don't have the money or the insurance to do so, you may suffer in silence and not seek out the treatment that could be available. And those with higher education also tend to seek out therapy. And so if we really want to make healthcare more accessible or therapy more accessible and kind of destigmatize mental illness in this country, those are some of those things I think that need to be addressed. And so on the flip side then of this is why people aren't seeking out therapy. This chart shows from the year 2012, people who did not receive mental health services, even though they were considered needing of them. The biggest factor is not being able to afford the cost. And so I think that's really problematic, considering we know that 1 in 2 adults will at some point in their life have symptoms of a mental disorder. So then if 50% of them aren't able to afford it, that's really, really troublesome. So just kind of knowing that helps us kind of like see maybe where we can improve as a society in the future in regards to that. All right, so those are just kind of people who seek therapy and why people maybe don't seek therapy. But now let's talk about the different types of therapists. And this was stuff kind of from the beginning of the year, so we're not going to spend a ton of time on it, but just make sure you can differentiate between a psychologist and a psychiatrist. Excuse me, I don't know why I have the yawns tonight. A psychologist can be a clinical or a counseling psychologist. Those that are clinical can treat like full-fledged disorders. Typically, if you were a clinical psychologist, you'd have a PhD and you could diagnose and treat most disorders. Counseling psychologists may or may not have a PhD. They could, they might not. And they treat more like everyday problems. So you might see someone like doing like family therapy or things like that. So it doesn't, again, have to be someone with a disorder that they're treating. Then we have psychiatrists, which are medical doctors. So they've actually gone to med school, which is different than getting your doctorate in psychology. Those are different things. And they tend to specialize in psychological disorders. So typically a psychiatrist would be treating someone who has a diagnosable disorder. Typically, we also see them treating the more severe cases, the more severe disorders, but not always the case. And then we have other forms of therapists, social workers, counselors, nurses, even sometimes you're like, if you go to like a church or a temple, your priests, your rabbis, they may have training in mental health services as well. And so not everyone that offers like therapy and counseling is like a certified psychologist or a psychiatrist. So just kind of keep that in mind. All right. And so then the different types of treatment kind of depend on who you're seeing. Different psychologists or different psychiatrists may offer different approaches. One branch of therapy that we see is called psychotherapies, and those are the more talk therapies, the sitting on a couch face-to-face, having a conversation with your counselor, and then working through the problems together. Those are our talk therapies. There's also another branch, which is biomedical, and so those are the more biological. factors. And so that would be like prescribing medicine, or maybe doing even like brain surgery or other procedures on the brain to help treat the disorder. Typically, what we see is an eclectic approach to psychology and to treatment. About 36% of clinicians today combine maybe some bio, maybe some psychological therapy, maybe some behavioral therapy. And it really is unique to each person. So depending on what your disorder is, what problems you're having, they may prescribe medication and, one-on-one therapy sessions. So it really is going to be dependent on what your needs are as an individual. There is no like one size fits all therapy for each disorder. So the eclectic approach, I think, is really good. And I think that's kind of the best, because just like everything we talk about in psychology, right? We have to look at the biological, the psychological, the social factors, and look at the whole big picture. And so that's why it makes sense for treatment to look at the whole big picture as well. Okay. And so the first strand of talk therapy that we're going to talk about is the psychoanalytic strand. And if you know the word psychoanalysis, you should immediately associate that to Freud. So that's who we're going to be talking about. And so Freud, if you remember, wants to discover our unconscious past and bring it to awareness. So Freud, again, thinks that all of our problems are buried deep down in our subconscious, and he wants to bring those to the surface so that we can solve our issues. Different things that may happen in a psychoanalytic session might be something called the free association. You might use hypnosis, dream interpretation, or even transference to like figure out the message. And so the therapist here is going to explain to you, the patient, the significance of your thoughts and your feelings. And then hopefully, once we release those thoughts and we release those feelings, that repression gives the patient insight and makes them feel better. This is a very lengthy process. Psychoanalytic perspective may take 3 to 5 years of therapy before it resolves. So you have to really be like dedicated and be able to afford it too, because it's super expensive, right? So being able to do that. And so some of the techniques mentioned that you should know, we've discussed free association before. That's where, like, if I say a word, if I say potato, what's the first word that pops into your mind? If I say mother, what's the first word that pops into your mind? And so as you start to talk then about these terms, the therapist is able to help uncover and unedit what you're saying, and allows us to then free those ideas. Resistance may happen when you're seeking out psychoanalytic treatment, and it's when you may like censor yourself or block out certain things. And so if the therapist can sense that you are resisting or that you're editing your thoughts, they're going to help try and figure out why you're doing that and what's causing you that anxiety. Again, to get to that unconscious and try to figure out what's actually causing you problems. The interpretation aspect then is when the therapist takes all of those things together, your dreams, your free responses, all of those things, and helps you discover what's happening. And then sometimes we might see something called transference, which is when if I'm in therapy and my therapist reminds me maybe a little bit of my mother, I might interpret or take those strong feelings, maybe of hatred towards my mother, and start putting them on my therapist because they're helping me uncover and work through those things. I transfer those feelings to the therapist. This can actually help the therapist then by like, oh, obviously you have some negative unresolved issues with your mother. Let's get down to the root of the bottom of those. So those are some of the aspects of what psychoanalytic therapy might look like. Also, psychoanalytic therapy is the kind of the typical one that we see on TV shows where a patient is like laying back on a couch and then the therapist is sitting behind them scribbling down notes. Typically, if we're doing psychoanalysis, we're not face to face. They're facing away from you. The patient faces away from you and you're taking notes and going, yes, and letting them talk and kind of freely writing down what they're saying. So, is this a good thing? Does this work? I would say the psychoanalytic approach is much more historical. Very few therapists today are going to use this. So it's not super common today. It's kind of outdated, just like a lot of Freud's ideas, right? We study Freud because he's important. He lays a lot of this groundwork, but today we've also revised a lot of that work and made changes. And so you still need to know it, but there are some problems with the psychoanalysis. One is that it's not backed by research, which is pretty problematic, right? We want things to be evidence-based and research-based. Also, the interpretation aspect is very subjective, right? Having a psychologist tell you what a dream means or tell you what a word means to you, that's super subjective. And if your therapist has any sort of bias, it can then impact your treatment and what's happening. And perhaps the biggest factor is that it takes a lot of time and a lot of money, like we mentioned. And so those are all kind of reasons why this therapy isn't used much anymore, but you still need to at least know the gist of it. All right. And so after psychoanalysis, this new offshoot that we see is the psychodynamic approach. And so this is the modern version or the updated version of Freud's approach. So this is the newer version. And so how does it differ specifically from psychoanalysis? The first thing is that it focuses on current symptoms. So this therapy is not trying to uncover some deep unconscious thoughts that are buried. It's focusing on your current symptoms, what's happening right now, today, how can we fix this? It focuses on relationships. It's more face-to-face. So again, it's not you laying on this couch facing away from your therapist. It's more personal. You're having a conversation back and forth. And it's shorter, which is a good thing. It doesn't take as long typically to see results. And then underneath there, we have interpersonal psychotherapy, which is an even shorter, so we're kind of going even shorter in time frame. It's a brief version of psychodynamic therapy. This might be for someone who's just having some relationship problems and they just need a little help kind of navigating them and getting through them. So this goal is like immediate relief. Let's fix the problem. So psychoanalysis is like the old school, very long, drawn out process. Psychodynamic is the modern approach. It's a little bit less long. It's more face-to-face, more personal. And then the interpersonal approach, shorter yet, immediate relief. Let's fix the problem. And so those are all talk therapies. They fall under that bubble because they all involve you talking to a therapist. The next segment of therapies that we're going to talk about are considered humanistic therapies. And so humanistic therapies are sometimes referred to as insight therapies because they're giving us insight or awareness into what's causing us problems. It's kind of like that light bulb turning on and helping us fix the problem. And so we've seen this pyramid before. This is Maslow's hierarchy of needs. And so the humanistic therapies kind of revolve around this idea. And that basically what the goal is we're going to boost self-awareness and acceptance. And so instead of thinking about the past, humanistic therapies focus on the present and the future. What can I do now, today, so that my future is better? And so it focuses on our conscious thoughts and promoting our growth up this pyramid, right? Our goal is to reach self-actualization, to become the best person that we can be. And so our humanistic therapist would want us to figure out how to do that. Maybe my feelings of safety aren't being met. So let's recognize why my feelings of safety aren't being met. And now what can we do in the future so that I do feel safe and I can move my way up the hierarchy of needs? And so a specific therapy that goes along with the humanistic perspective is what we call client-centered therapy. And you need to know the name Carl Rogers. He's an important name that is associated with this perspective. And so what client-centered therapy is very supportive. Remember, the humanistic perspective is our touchy-feely perspective. It's all about love and growth and acceptance. And so therapy in this perspective is also all about love and growth and acceptance. And so it's very supportive. It's an emotional climate for the client. The therapist has to be very genuine. They have to be empathetic. And they have to have what we call unconditional positive regard. So no matter what's happening in the patient's life, the therapist kind of has to try and put a positive spin on it and make them feel okay or good about it. And so the therapist is really there to guide the client in their process, in their journey. And so the client actually leads the therapy themselves. So the patient comes in and the therapist just listens and lets them talk and lets them air it out. And they agree with them. It's very empathetic. It's very caring. And the goal here is to resolve any inconsistencies that may be happening between what your self-concept is and your reality is. And so we want to see self-acceptance. We want to see personal growth. And so again, like this picture, you are awesome, unconditional positive regard. You deserve love. You deserve happiness. Let's figure out how to do that for you. Very, very positive, very touchy-feely. Client-centered therapy is also, there's some, normally I would have us watch this clip, but tonight's session's a little long. But basically the therapist is talking through with a patient using unconditional positive regard and client-centered therapy. And so if you were to write up a dialogue, basically what you need to know is that if you were a client-centered therapist, you'd paraphrase someone's feelings back. And so if someone's saying, I just feel like my husband doesn't listen to me and my kids don't care and I just don't feel respected at my house, the therapist would then turn around and say, I hear you saying that you don't feel respected. Let's talk more about that. So they just change what you said a little bit, repeat it back to you, and let you keep going and clarifying. So they reflect your feelings, they reflect what you're saying. And so a good client-centered therapist would use a lot of paraphrasing, clarification, and feelings. That's kind of what we're going for there. After the humanistic perspective, we're jumping into the behavior approach to therapy. And so if you think back to the learning unit, we talked about a lot of principles of behaviorism. And the two big things were classical conditioning and operant conditioning. And we can use both classical and operant conditioning not only to teach someone to do something, but we can also use those in therapeutic ways. And so behavioral therapists may use these approaches to help kind of train someone to like fix their problems or adjust. Just some famous names that you know that are associated with behavioral therapy is Skinner, Eysenck. I don't know that you really need to know Wolf and Douglas. Probably Skinner is the most important of all of those names. But so if you remember back, this is some good review to the behavior unit. Classical conditioning was one way that we could train animals or humans to do or respond in certain ways. And so we could also use the principles of classical conditioning to sort of rid somebody of an unwanted behavior. And so how we do that is, remember, in classical conditioning, we pair a neutral stimulus with a new response. And so then we can get rid of that unwanted behavior. And there's two main ways that we can do this. This is called counter conditioning because we're training someone to not respond or have like an unwanted behavior. So we're kind of like almost undoing the conditioning or giving them a new response. And there's two ways. So there's systematic desensitization and there's aversive conditioning. Both of them work. They might be used for different reasons, and we're going to look at both of them on the upcoming slides because they're pretty important. So for systematic desensitization, we might use exposure therapy. And this one in particular works really well with phobias. So if you are ever, thinking about what therapy might work best for phobia, this is probably it. So we can counter condition your fear to not be fear, basically, is the presence here. So to start with, first we have to create a hierarchy of your fear situations, your anxiety-producing situations. So let's say your fear is flying. That's why I have a picture of an airplane here. So the thought of getting on an airplane and flying somewhere just sends you into absolute panic. You just can't even think about it. So we create a hierarchy here of things that produce anxiety for you. Maybe the low level thing is just even looking at an airplane makes you a little nervous. And then maybe the next hierarchy of anxiety is talking about flying. That makes you feel pretty anxious. And then even higher up is like going to the airport and seeing airplanes. That makes you feel pretty anxious. And then like the highest, obviously, like phobia, anxiety producing thing is actually getting on an airplane and flying. So we've created this hierarchy of things that makes you feel uncomfortable. We've identified those problems. Then, as a therapist, I'm going to train you how to relax yourself. We might try meditation, we might try deep breathing, whatever it is, I'm going to train you in principles that allow you to just relax, calm, and center yourself. Then after you've got that down, you know how to like train yourself or calm yourself down, we go back to that hierarchy that we've created. And we start at the very bottom. So first, I just show you pictures of airplanes. And when I show you those pictures, you start to, you do your breathing techniques, your calming techniques, and you go into that relaxed state. And so then anytime I show you an airplane, your response is to be calm and relaxed. And then from there, we go on the next step up. Maybe we start talking about flying. And then again, that instead of turning to anxiety, you practice those relaxation techniques until you can talk about flying while feeling calm and relaxed. Then we might go to an airport for our therapy sessions and just sit there and you feel that anxiety, and we practice those calming, those relaxation techniques until being in an airport doesn't give you that anxiety anymore. And so basically what systematic desensitization is the step-by-step process that's training you to relax and meditate in response to something that initially gives you fear. And so we're classically conditioning, instead of anxiety, we're classically conditioning calm and relaxed. And so that's the ultimate goal then, is to get you on an airplane flying and feeling calm and relaxed. So you could imagine how this would work with a lot of different phobias. Fear of animals, same sort of thing, looking at pictures to eventually like touching or holding an animal that you're afraid of. You could do this in real life, like I said, going to the airport, getting on an airplane, doing those things. Or we could also use with like the new technologies we have, a lot of times virtual reality therapy is accessible and helpful, and so sometimes therapists employ that. But that's one way that we can use classical conditioning principles to kind of train you to not feel that anxiety or that fear. And again, in particular, this is really useful with phobias. The second way that we can use classical conditioning is through aversive therapy. And so this is a type of counterconditioning where we associate a negative or an unwanted response. And so if you look here on the screen, there's, let's say that you're wanting to quit drinking alcohol, but you're having a really hard time. And I have this drug that I can give you that makes you feel nauseous. So the drug automatically elicits a nauseous response from you. If every time you drink the alcohol, I put the drug in the alcohol, what is that going to make you feel? Nauseous. Eventually, then, you're going to be conditioned that that alcohol also makes you feel nauseous. And so the new response to alcohol isn't feeling good or whatever you're getting out of it. It's that feeling of nauseous. So we've counter-conditioned you to feel that way. And there's a short clip here from the TV show King of the Hill that shows counter or aversive conditioning in practice. This is something I think we see in a lot of TV shows with kids and smoking. It's just a short clip, but we'll watch it really briefly. Maybe, yes, okay. So he's smoking all these cigarettes.
Come on, only one pack left.
I think I'm gonna barf.
That's what I wanted to hear. Good job, son. When you're finished, you want to get that with a hose?
So I think we see this sometimes play out on TV shows, right? This idea of like, oh, your child was caught smoking cigarettes, so what we're going to do is make them smoke like 10 packs of cigarettes so they feel sick, and then in the future, just the thought of cigarettes makes them feel sick. That's an example of aversive conditioning. It's conditioned like a negative or an unwanted response with the thing that you're trying to stop doing. Besides then classical conditioning, we could also use operant conditioning to train you to get rid of an unwanted behavior. This works well with little kids especially, which is why I have my little princess chart up here. But basically what we would do is use called a token economy. And then in token economy, every time you do something good, which is our desired behavior, you get a sticker or a token or whatever. And then those things can be redeemed at a certain level for privileges or rewards. So again, you see this a lot of times with little kids, right? Like they have their little chore chart. That's what this is. So the princess is working towards, I don't know, a trip to Chuck E. Cheese. And so every time she does something good, she gets one of those thumbs up stickers. And once she fills up her chart, then she gets her reward. That's how a token economy works. And so we can use that in conditioning for someone. Let's say that I want to really go on vacation to the Bahamas with my husband. And so, and I'm trying to quit smoking. So every time I don't smoke a cigarette, like every day that I go without buying a pack of cigarettes, I get a reward. And if I reach 100 days in a row of not smoking or whatever the goal is, then we can take that trip to the Bahamas. We can take that money that we saved not buying cigarettes and put it on a trip to the Bahamas. So that would be an example of a token economy. It's kind of like bribery a little bit, but that's how it would work. And so the reward has to definitely be something desirable, because it's something that you really would want to try and work for. And so we can condition people through that operant technique of the token economy. All right. I know we're hitting a lot of therapies here, but this is kind of a big overview of the unit. So after behavior therapies, there's now cognitive therapies. And so we know cognitive has to do with thinking and thought processes. And so if I'm a cognitive therapist using these methods, basically I think that there's a problem in your thinking. Like your thought process is what's causing you the distress and the dysfunction. And so I want to teach you a better or more constructive way of thinking. And so in cognitive therapy, let's say the situation is that you lose your job. And so you might think, oh my gosh, I'm worthless, I'm hopeful, or I'm hopeless, I can't do anything right. And if you have those sorts of thoughts, I could see how it could easily lead to someone into a state of depression, right? But a cognitive therapist might help you change your thinking, like, but my boss was a jerk and I deserve better anyways. That's much more hopeful, that's much more positive. And so instead of falling into a depression, we can change our thought process. That's not to say that someone with depression can just think happy thoughts. Like we know that that's not true. But if we can teach people better ways of coping in stressful situations, better ways of approaching problematic things, we can help maybe mitigate some of those symptoms and some of those problems. And that's the goal with cognitive therapy. And there's a specific strand of cognitive therapy called Rational-Emotive Behavior Therapy, REBT. And it's created by a man called Albert Ellis. And this is a more confrontational style of therapy. It's not confrontational like mean, but it's confrontational in the fact that, like, if I'm in therapy, I'm like, well, gosh, nobody will ever love me. It's just so hopeless. Nobody likes me. And then your therapist might challenge you and they might say, well, didn't you say last week that your mom called to see how you were doing and she said she cared about you? That's someone that loves you. And then it's changing your thinking, right? It challenges those like really negative thoughts that you're having, and it replaces them with like the truth. And it's helping you see that how illogical it is to think those things. And so you might use what's called the ABCDE model of rational emotive behavior. And so what happens is there's some sort of activating event. Let's say your significant other breaks up with you. That's the activating event. The irrational beliefs then that happen is that I believe that no one's ever going to love me because my significant other with me. The consequences of feeling like no one's ever going to love me is probably depression, sadness, anger, things like that. Therapist comes in here at the disputing irrational beliefs, and they would say, well, last week you said you got dinner with your best friend and she was really supportive and caring about you and told you that you could call her anytime you needed anything. So she's someone that cares about you. It's not hopeless, blah, blah, blah. And so they're disputing those irrational beliefs, which in turn leads us to E, an effective way to think and behave. And so it's all about changing those thoughts and fixing those sort of problems. Because I think we all can get stuck in these cyclical thoughts of like nothing ever goes right. Why does everything bad happen to me? And things like that. But if we can just sometimes challenge those thought patterns, we can really like help ourselves a little bit approach situations in a more positive way. Again, probably not going to cure depression for anyone, but it can help someone cope with stressful situations that can like lead on bouts of depression and things like that. So it's pretty important to have that therapy. So this is also considered a talk therapy, right? You're sitting down. It's more of a face-to-face conversation, but it is considered a talk therapy as well. And then another name that goes along with cognitive therapy is Beck. You need to know the name Beck. And this is like, with the cognitive approach, Beck feels like people blame themselves, which then leads people to focus on the negative, which then makes us make pessimistic projections of the future, and then we draw negative conclusions about ourselves. So if I'm a cognitive therapist, I'm trying to help flip all 4 of those bullet points. You shouldn't blame yourself. It's not your fault your boss is a jerk. Don't focus on the negative that your significant other broke up with you. Focus on all of the friends and positive relationships you have. Don't be pessimistic about the future. You have X, Y, and Z to look forward to. And so this idea, again, of cognitive therapy is challenging these negative perceptions and these negative viewpoints and turning them into more positive circumstances. Or even, not even positive, but just different ways of thinking about them. And then the last thing that deals with cognitive therapy is what we call stress inoculation training. And this is just practicing changing how you think in a stressful situation. So we all have this AP test coming up that might be a little stressful for some of us. We might be anxious, we might be nervous. So before an AP Psych test, we might say, oh my gosh, this test is probably going to be impossible. Everyone else seems so relaxed and confident. I wish I was better prepared. I'm so nervous, blah, blah, blah. That's not a good way to approach a stressful situation. Again, that negative cycling makes us feel negative, which probably will fuel negative results. So instead, change your thinking in a stressful situation. Consciously sit down and challenge those negative thoughts. I've studied hard. I know I'm prepared. I'm going to do the best I can. So challenge those negative thoughts with rational, positive thoughts, and then think through it in those ways. And so stress inoculation training is just practicing that in stressful situations. Your therapist might give you like a script to go through in your head, but again, it's just challenging that like stressful, anxiety-producing thought process and giving you a more positive, concrete way to think about things. All right. Then we have a sort of eclectic approach where we can combine the cognitive and the behavioral approach. So this is called Cognitive Behavioral Therapy, or CBT. And this is an integrative approach where we are both fixing the thinking and the behavior of a situation. This is particularly useful with OCD. So this is one that we would often use with people with obsessive compulsive disorders. So the cognitive aspect, we might relabel people's obsessive thoughts. So if I feel like I have to constantly wash my hands because I'm afraid of germs and it's just this obsessive thought that I'm fearful of germs and getting sick, the therapist is going to help you recognize that. I'm having a compulsive urge to wash my hands because of my brain, not because there's actually scary germs on my hands. So you confront that thought, you label that thought, and you think about it. There is not an actual reason that I need to obsessively wash my hands. It's just my brain is telling me to do it, and I know that that's wrong or incorrect. So first you have to think about it. You have to cognitively label what's happening and then relabel it as an obsession. I know it's an obsession. And then to avoid that compulsive act, do something else. Every time you get that urge to wash your hands, maybe you go outside for a walk, or you, I don't know, chew a piece of gum, whatever it is, you do something else. And so then that gets rid of the behavior. You're altering that behavioral approach as well. So it's the cognition. It's recognizing that that thought is due to my OCD. It's due to my brain. It's an obsession. And then now I'm not going to dwell on it. I'm going to go for a walk and avoid doing that compulsion. And that's one way that we can attempt to treat OCD. Medications are also going to be useful. We'll talk about those a little bit later. But again, if we're taking an eclectic or an integrative approach, that may be one, thing that we want to do. There's other alternates here in talk therapy. Other things we might use might be things like social skills training. We might feel a lot of anxiety and things like that because we just don't feel socially adept at coming into situations. We might feel inferior. People with autism or ADHD or schizophrenia might really benefit from these social skills training. So again, this isn't necessarily therapy, but it's an approach that can kind of help mitigate, again, maybe some of those anxiety producing situations. Lifestyle changes are also beneficial sometimes, just getting exercise or more sleep or creating a social connection or even sometimes nutritional supplements. All of these things can help. Again, by itself, is exercise going to cure your mental illness? Probably not. Combined with other therapeutic measures, it could have a positive impact. And so it's important to, again, look at a holistic picture of treatment, not just focusing on one specific approach, but really trying to come at it from all different angles is probably going to get us our best results. So those are all of our talk therapies that we've talked about. Another example of talk therapy could be like group therapy. I don't know that you need to know a ton about these. They're mentioned in the textbook. They're pretty straightforward. If you can't afford one-on-one therapy, sometimes group therapy might be beneficial. And so a therapist might have a group of people who all have similar problems. And so we might have group meetings about it. It saves time and money. The clients can kind of help talk each other through things like that. Family therapy, especially with the humanistic approach, that be beneficial if you're having some sort of problem in your hierarchy that involves relationships, dealing with like fixing a relationship with your mother or with your siblings or things like that might help you. And then we also recognize things like Alcoholics Anonymous or Narcotics Anonymous, self-help groups for eating disorders, drugs, alcohol, things like that are also pretty beneficial. People who are going through the same problem as you might be able to help you recognize things that are going on, give you strategies and tips to help you through those things. So all of these are sort of kind of talk therapies, but they're more group-based, so they're not as individually tailored to you as a person, but still could be beneficial. So those are all of the talk therapies. If you want to screenshot this chart or take a picture of it, it gives a really good summary of what the problem is, how the therapy tries to approach it, and then the techniques that are used. Our book, I use the Myers textbook, has a lot of these little charts in it, and I find them to be very useful when you're just trying to quick study or review like a concept. So I'm giving you a second, take a picture, screenshot it, whatever you need to do so that you have this chart. Or if you have the Myers textbook, it's in your textbook. You can take a look at it. But yeah, I tend to find those to be useful. So those are all of our like modern talk psychotherapy type things. We're going to now move on to talking about the biomedical approach. I'm going to skip through. I had some practice questions. I will have them posted to either the Facebook page or to the content for this class so that you can look at them. But basically, there was just some scenarios, and you had to identify the type of therapy that might be used or be beneficial. Like I said, we're kind of running short on time, and I want to get through the bio approach. So I will find a way to post these to you. And next week, we'll probably start our social psych with a little bit of review. So we can come back to some of those at that point. So tune in next week. We'll come back and do some review on that. All right. So moving on now to the second kind of strand of treatment, it's the biomedical approach, so medicines, biological factors. And there's three main ways that we can take the biomedical approach. We could use medication, we could use surgery, or we could use brain stimulation. So we're first going to talk a little bit about the different groups of medicines that exist. for the AP test, you do sometimes need to know some drug names. It's not super common, but once in a while they do pop up on the test. And so there's 4 main groups here, and I'll talk about each one more in depth, so I won't spend a ton of time now, but there's anti-anxiety drugs, antipsychotic drugs, antidepressants, and mood stabilizers. Anti-anxiety medication is used for anxiety, hence the name, anti-anxiety medication. And basically what happens is it depresses your central nervous system. So think about when your sympathetic nervous system kicks in when you feel anxiety. What's happening? Your heart rate is increasing, your breathing's increasing, you might even start to like sweat and get jittery. And so what anti-anxiety meds tend to do is to kind of dull those reactions. It brings them down. And so Valium is an example, Xanax is an example, and benzodiazepines, which are tranquilizers, are all examples of things that may be prescribed as anti-anxiety medications. And the side effects kind of make sense. If it's depressing your central nervous system, if it's bringing those things down, you might feel drowsy, you might feel depressed, you also might feel nauseous, confused. There's also risk of becoming drug dependent with any sort of medication, overdosing, and withdrawal. And so there's pluses and minuses to medication. Meds are usually pretty helpful for like a quick turnaround and feeling better. But the problem is if you ever stop taking them, then the problem tends to come back if you haven't actually addressed the whole problem. And so we would like to see, besides just medication, some of the times using then some more of those like talk therapies and things together so that we can like address the problem completely. Antipsychotic medications are sometimes used to relieve hyperactivity, someone who suffers from hallucinations or delusions. So when we get into like schizophrenia, that's one that we tend to see, and mental confusion. And so basically we want to get rid of those hallucinations. We want to get rid of those delusions so that you can live a quote unquote more normal life. And so what an antipsychotic med is or does is it's a dopamine antagonist. So what does that mean? An antagonist blocks or prevents. Remember, it blocks or prevents. And so what they do is the medication that you take actually binds to the dopamine receptor sites and it prevents them from firing. So it's thought that people who suffer from schizophrenia and other like sort of psychotic mental illnesses have too much dopamine. And so what the drugs do is prevent the dopamine from firing. So you get less dopamine. Examples of drugs that are antipsychotics are Thorazine, Mellaril, and Haldol. I think Thorazine is the most common. I think that one has been on an AP test in recent years. So just throwing that out there. Side effects, again, drowsiness, that tends to be a side effect for a lot of these. Constipation, cotton mouth, muscle tremors, rigidity, impaired motor coordination, obesity, diabetes. And so again, like medications are useful. They can give you relief, but then look at all the side effects that you suffer from. A lot of people who take schizophrenia medication or antipsychotic meds don't like being on them because it's mind numbing. They don't feel like themselves. And so that's one of the reasons why schizophrenia has such a high recurrence rate, is because people don't like how they feel on the medications, and so they stop taking them. And that's a problem, right? Like people shouldn't feel like they aren't really living or that they aren't themselves when they're on these medications just to get relief from some of their symptoms. So it's like you kind of have to like weigh the odds there, which is better, feeling constantly like not well because of the medication or not having the it's a tough situation. And that's why sometimes these illnesses have a high recurrence rate, because as soon as you go off your meds, you start experiencing those things again. All right, antidepressants are drugs for depression. So first we had anxiety medication, antipsychotics. Now these are for depression. And they're designed to elevate your mood. And sometimes antidepressants are also used to treat anxiety. So it kind of depends on what your therapist thinks for your situation. But what antidepressants do is they are norepinephrine and serotonin agonists. So if antagonists block receptors, agonists make sure we get more of it. So if you ever have taken, this is very common, an SSRI, it's a selective serotonin reuptake inhibitor. What that means is as my neurotransmitters are released in my brain, serotonin's flowing around, what happens is that Prozac or Paxil or Zoloft or whatever medication I'm on prevents the serotonin from going away. It makes sure that the serotonin gets absorbed by like the next neuron and the next neuron and the next neuron as we go. So it prevents the serotonin from getting reuptaked back, and it makes sure it stays around longer so that our body uses it basically. And so that's what an SSRI is. We also could see an SNRI, which is a selective norepinephrine reuptake inhibitor. And it's the exact same thing, but instead of the serotonin lingering, the SNRIs make sure that the norepinephrine stays around. And so examples of those brand name drugs would be like Effexor. Prozac and Zoloft, I think have popped up. I can't remember for sure. Once in a while, drug names pop up on the AP test. But I think it's more important for you to know like how they function. So understanding that it's making sure that the serotonin or the norepinephrine stays around longer so that our body can absorb it. That's kind of the key. And then we have the last classification of drugs, which are mood stabilizers. There's two main mood stabilizers on the market. There's lithium. Lithium has a whole host of problems with it. It's used to treat bipolar disorder. It's toxic. Basically, it eventually causes all kinds of organ failure and things like that. And so we really don't like prescribing lithium. But to treat bipolar disorder, sometimes we have to. And there's a newer drug on the market now called valproate. It's a version of lithium. It has some of the same effects, but it is less yucky, basically. And so lithium is more of an old school method that was used to treat bipolar disorder. And now we're starting to see better results from something like valproate. And so these drugs have to stabilize mood because remember, bipolar disorder is kind of the extremes of like the really high highs and the really low lows. And it tries to keep you more in the middle, like the quote unquote, like normal range. All right. So drug therapy, is it effective? Couple of things we should know. Yes, medications work. If you're taking medications, right, I have in the past been on anti-anxiety medications. It helped me through some problems and some things in my life. But we need to be aware of some of the problems that come with medications. First and foremost, meds aren't always as effective as advertised. So pairing those medications with other forms of therapy are sometimes beneficial. I don't know why this thing is up. Also, as we mentioned, there's substantial relapse when the drug therapy is stopped, right? If I stop taking my antidepressants, but I never got at the root cause of the depression, what's probably going to happen is my depression may come back. We've also seen in recent years a rise in over-medication and over-prescription of drugs. It's a very profitable industry, and sometimes it's easier to write a prescription than it is to actually treat someone. And so we should be cautious about, long-term being on medications without actually addressing some of the concerns that go with them. As we saw with some of the medications, sometimes the side effects are actually worse than the illness themselves. And so then it's like, which one, you kind of have to choose the lesser of two evils, and it's difficult. And another problem is that often pharmaceutical companies are the ones that fund the studies into these drugs. And so obviously they're paying to make results look a certain way so that they can profit from them. And that can be problematic in the long term for people who actually rely on these medications. All right. Ooh, we are cutting it close with time. Brain stimulation is the second strand of biological therapies then, and there's two main examples of brain stimulation therapy that we might see used. One is called Electroconvulsive Therapy, and then the other strand is called Alternative Neurostimulation Therapies. So, electroconvulsive therapy back in the day might have been called like electroshock therapy. We try to be a little bit better about how we use it now, although it still is literally causing someone, you're literally shocking someone. So what's happening in this picture is they're hooking you up to these electrodes and they're basically causing you to have a seizure and convulsions. Seems super barbaric, right? Seems like something you wouldn't want to sign up for. However, it has been shown to help in some cases with severe major depression. Like things just aren't working, things aren't helping. And so using this has sometimes shown success. And so people might willingly sign up to have this convulsive therapy done. About 8% of psychiatrists do use this. So not super common, but it is used. Some of the problems associated with it might include memory loss, cognitive problems, but we also sometimes see improvement of the actual major depression. So again, you have to weigh the risks and the consequences with what the actual disorder is that you're suffering from and make a decision that's best for you. So that is one then example of brain stimulation. Another is these alternative neurostimulation therapies. This first one is called repetitive transcranial magnetic stimulation. And so RTMS is shown here in the pictures. There's literally these like coils placed over your head. And what's happening is they're sending like magnetic impulses into your brain. And what they're trying to do with this therapy is that they're basically trying to like kickstart part of your brains that may be inactive. And so they're hoping that maybe, part of your brain that's associated with depression just isn't helping and working enough. And if we send these magnetic fields into your brain, we can actually kickstart them and get them to work. It's been shown to work modestly. Sometimes the results are not as long-lived, but there have been results with it. There seems to be less side effects with this than the actual like shock therapy, which is probably good. And so it's something that's gaining some traction. We're still trying to study and figure it out because like we aren't sure 100%, all of the effects and things like that. And then there's something called deep brain stimulation. And if we chose this method, we actually would do surgery and implant electrodes into your brain. So we would go inside the brain, implant the electrodes, and then we can, when we want to, turn those electrodes on, and those electrodes then can actively stimulate parts of the brain wherever we're pinpointing whichever part of the brain to activate those neurons and those neurotransmitters in your brain to be higher functioning and more active. Again, tends to work. These are pretty extreme things, especially like deep brain stimulation, because it's involving implanting things into your body. But if alternative therapies and methods haven't worked and you really need relief of your symptoms, it may be something to look at. Your doctor may prescribe or look at with you. A couple more slides. And then the final, most dramatic option is actual surgery, brain surgery on your brain. It's irreversible, right? Once we've cut part of your brain away or operated on it, we can't go back and undo it. And so this is used pretty rarely. This isn't like a common, oh, hey, I'm just going to have brain surgery, right? It's not a very common thing. But again, in extreme cases, it might be used. Remember last time or 2 times ago, we talked about lobotomy. Lobotomy was kind of the original brain surgery. Nowadays, we do it very precisely. We do it very sparingly, and it might be used for things like obsessive compulsive disorder and seizures. And so, again, we have to weigh the risks to the rewards and kind of figure out which method is going to be most beneficial without causing you too much harm. And then lastly, this is sort of an eclectic approach, I guess I would say, but therapeutic lifestyle changes are things that your doctor or therapist may recommend. They're not talk therapies. They're not necessarily biological therapies either. They're more holistic ideas. And basically, it takes into approach this idea that our mind and our body are connected. I can't just treat my mind and I can't just treat my body, but they work together. And so we have to look at a lot of these disorders as containing both psychological and biological stressors. So again, exercise, sleep, social connections, things like that have actually been found to alleviate some symptoms of disorders. Again, it's not going to cure you by itself, but adding in some medication and some exercise and some talk therapy, taking that holistic approach may have better results than just doing one of them on their own.